Hello, my name is Dylan Atkinson. I'm a third year medical student at Ohio University, and this is my case report. Unusual presentation of vasopressor-induced peripheral ischemia in a patient with septic shock. I'd like to thank the patient and their family for allowing me to share their case information for our educational purposes, and the symposium for allowing me to make the presentation. Case introduction. 69-year-old female with a past medical history of type 2 diabetes and coronary artery disease. She presented confused to the local emergency department at night. She was found to have hypotension and fever and also lactic acidosis. The diagnosis of septic shock was made and criteria are outlined in the top right-hand corner. Despite maintenance of her mean arterial pressure with fluids and a very brief course of norepinephrine, she developed dusky discoloration and pain in her distal extremities, which resulted over the course of a week in dry gangrene. The presumptive diagnosis was made, vasopressor-induced peripheral ischemia. She was sent to a larger center for specialized care under vascular surgery. These images highlight just how severe this case was for the patient and why it was a truly memorable case that we can learn a lot from here. She had bullous and necrotic changes in her feet, which was very diffuse, and in her fingers involved every digit except for her thumb on her right hand. Broad spectrum antibiotics were adequate to control her sepsis, and oral midodrine was adequate to maintain her core perfusion for a week. And all of her other issues resolved, but this is one issue that, despite best efforts, progressed to amputation, which is truly morbid and unfortunate for the patient. The vascular studies that were obtained during the workup included Doppler studies and CT angiography. The CT angiography is displayed here. It demonstrates that beyond the left and the right anterior tibial arteries, there is no distal blood supply found. The contrast dye effectively ceases before it even makes it to the malleoli, before it passes the ankle and gets to the foot. All of her, all of her digits of her hands and her feet were receiving no oxygen. It's the most likely explanation why she had this morbid outcome is that there was no oxygen being delivered to those tissues. And our best guess at the time was that it was the vasopressors that did this. So, discussion. Septic shock is a condition with a high incidence of burden in critical care medicine, estimated mortality over 40%. IV norepinephrine is first line for distributive shock, and in rare cases, IV vasopressors, particularly multiple agents and high dosage for multiple days with pressors such as norepinephrine, vasopressin, and dopamine being given at the same time have resulted in case reports of peripheral ischemia and gangrene that resulted in amputation. But notice all the criteria that I highlighted to reach that conclusion. Multiple vasopressors administered concomitantly, presence of vasopressin and dopamine, several days, high doses, morbid outcomes. This patient, her vitals were stable, required only fluids in less than 24 hours of a tapered and conservative dose of norepinephrine. So it begs the question, how did this happen, and how can we stick with the definition of vasopressor-induced ischemia? Let's consider our diagnosis of exclusion, which is symmetrical gangrene. By definition, it's a result of coagulopathy. It also is considered a derm diagnosis of exclusion and requires the presence, strongly needs the presence of either levato reticularis or palpable purpura, and neither criteria was met here. So, and truly an unusual case of vasopressor-induced ischemia in these digits. This case underscores the severity and the complexity of this diagnosis and this outcome, especially in the context of septic shock. What was remarkable was that there's a lack of clear guidelines on dosage and duration using vasopressors in these situations. There's not there's not literature that states that that determines like what truly is an excessive dose or dangerous dose of IV norepinephrine. We treat patients with preservation of life over limb, and critical care physicians and physicians that are treating septic shock really are not thinking about the possibility to induce peripheral ischemia in these patients. I don't believe that it's something that's in the back of the mind of most of the physicians. And that was evident by how truly off guard and shocked the medical team and was when this condition erupted. So my hope is that this report can help bring awareness to gaps in our understanding so that we can contribute to the growing body of knowledge on intensive care best practices. Thank you very much.